Okay, future PCT EKG certified students, we are going to go over the section 5 heart blocks. So this is the last section of our EKG interpretation. We're going to go through, give you a poem, give you some other ways to remember, and show you the different types of rhythms with heart blocks that will be easy to identify for you. So what we're going to do, I'm going to share my screen with you, and we are going to go through some of these different rhythms, okay? So heart blocks, there are 4 different types: a first degree, a second degree type 1 and 2, and a third degree conduction block, okay? Let's review a little bit of the anatomy. This, as you can see, is the placement of the heart. I think it's pretty relative to size, and as you can see, it's a little bit more central. Here are the bronchioles moving into the lungs. Here is the heart with the apex, as well as the aorta that feeds oxygenated blood throughout the body. Here are the carotid vessels where you could feel the carotid pulse. All right, we're going to talk about the 4 different rhythms, causes, symptoms, as well as treatments. Some key terms for you to know as we go through here. We're going to talk about pacemakers, angina and how nitroglycerin can help, and coronary artery disease. All right, starting with pacemakers. This is a pacemaker, obviously in the hand of a healthcare provider, showing you the relative size of a typical pacemaker. This is a pacemaker that is a little bit older, and you're going to start to see pacemakers that are quite a bit smaller, but many people still have these pacemakers in place, and you need to be familiar with those. Pacemaker placement can either be in the left or right of the patient's chest, and a lead wire comes from that and moves all the way into the heart. Here is a pacemaker shown on an X-ray or radiograph, and it is shown in the left chest, and it would be just underneath the skin, but they usually take an X-ray after placement to make sure that the lead wires and everything are exactly where they think they are. All right, the evolution of pacemaker technology in the 1950s, many of these were large, cumbersome apparatuses, and they had to be put in externally for short-term use. In the 80s, they came out with an implantable pacemaker, still quite a bit smaller, but as we move through into the early 2000s, you can see that they have been a little bit bigger, but they also can do ventricular and atrial pacing. And more recently, a tiny implantable pacemaker, which you'll start to see more often as these wear out and people come in for replacements. For these new, smaller pacemakers, they implant those into the ventricular wall by entering through the groin and inserting that pacemaker in through a small little cable and implanting it that way. So the patient would end up with a much smaller scar. This probably is not the actual size. I did blow up this picture a little bit, but it is very small. How would you know if a patient has a pacemaker? Let's say they come in, they're unconscious, and you have no idea. Hook them up to some telemetry or an EKG, and you're going to see these pacemaker spikes. You might see 2 for every rhythm if they have atrial and ventricular pacemaker. These 2 can fail. If you see the pacemaker spike here, and then the P in the QRS, and the repolarization of the T, and another pacemaker spike, another rhythm, and then there's nothing, and then some crazy QRS that is wide and abnormal, and again, a wide and abnormal, that means the ventricles were expecting something, nothing happened, so the AV node took over and created this QRS, wide QRS complex. And all of a sudden, we see that the pacemaker steps back in. So this would be a patient who needs to have a pacemaker replaced, or it is malfunctioning. Angina, our second topic, is chest pain. Pain in the heart with activity or exercise. And this could be a warning sign that this patient is at very high risk for a heart attack. Angina is the result of a blockage in one of those coronary vessels. And as we've talked about before, coronary vessels or coronary arteries are the vessels that actually feed the myocardium or the actual heart muscle. And if it is not getting oxygen, we have a situation where the heart muscle cannot do its job because it is starving for oxygen. We can use a medication called nitroglycerin to open up those coronary vessels and allow a greater amount of blood that's oxygenated to that muscle. And often that can relieve the chest pain that we term angina for that patient. And typically this is a medication that can be carried around with the patient who's worked with their cardiologist to relieve chest pain. And they can put the tablet underneath their tongue. We call that sublingual, and it will dissolve and in turn open up those coronary vessels. Sometimes they use a nitroglycerin patch or a paste covered with a patch to be absorbed transdermally and allow those vessels to open up. Coronary artery disease is our third area of interest here, and I wanted to talk to you guys about how coronary artery disease is so closely related to some of these heart arrhythmias. Understanding coronary artery disease is understanding that the lumen or opening in those arteries and the coronary arteries is impeded by buildup of cholesterol or plaques. A result is a lot of coughing and discomfort and angina. All right, so here's a cross section of a vessel with some mild buildup of plaque, all the way down to a severe buildup of plaque, which inhibits blood flow from going through and, of course, increases the blood pressure of that patient. Here is how coronary artery disease can lead to heart attack. So here we have these red blood vessels, and we have just a little plaque here, but still a great amount of open lumen area for those red blood cells to move through. Angina is when a lot of that coronary artery or other arterial lumen is occluded by these buildup of plaques, and it's hard for blood to get through. So that heart muscle starts to give a pain signal with that lack of oxygen, kind of like if you sat on your foot for too long and it started to fall asleep because of lack of blood flow and oxygenation. So if a piece of this plaque were to break off, then a heart attack could occur because a piece of that plaque would completely eliminate the passage of any blood flow and cause some backup of blood flow. And all of a sudden that cardiac muscle is starving and it's going to start to get dusky and blue and then gray and black if we don't open that back up and that tissue starts to die off. What does a block actually mean? So now we're going to move over after we've gone through some of that terminology, and we're going to talk about AV heart blocks. So when we talk about blocks, I want you to think about a conduction interruption. There's not a physical block sitting in the heart impeding this blood flow, but it's a problem with conduction. So the heart is not beating like it should to give efficient pumping. Heart blocks are poor or no communication. And that's why I put a picture here of this mouse chewing on the wires, because as that deterioration of the conduction starts to happen, the conduction will be slowed or lagging. And if there is a complete absence of conduction, then we have a more severe heart block. This is different than junctional rhythms that you've learned about in the last few weeks, where the P is just lazy and completely absent. So in these, you're still in heart blocks, you're still going to see a P wave coming from the atria, but it might take a long time for the ventricles to answer the phone, or they don't answer at all because there is complete deterioration of that conduction. Okay, so some anatomy here. The SA node sits here, the AV node, as you know, sits here. Then we have the bundle of His and the right and left bundle branch blocks, bundle branches, and the Purkinje fibers here. So if there is a block between the SA node and the AV node, which would be the atrial and moving into the ventricular rhythm, then there's a conduction problem. All right, so here's an overview of the different types of blocks. We're going to talk about 4 different ones: a first-degree block, second-degree Mobitz type 1, second-degree Mobitz type 2, and these kind of go together, and then the third-degree block. So we'll come back to this, and I have some other comparisons for you as well. Okay, with a normal rhythm, we have a P and a QRS, and then the repolarization, T wave. And this one looks like it's a normal rate as well, 60 to 100. With a first-degree AV block, you're going to see that there's an extended PRI or PR interval, because it's taking a long time when the AV node, or excuse me, the SA node is calling the AV node, and that just means that the PRI is going to be greater than 0.20 seconds. So you can see that this is lengthened compared to the PRI here. So the rhythm is still regular and still normal, but that PR interval is just elongated, and that just means a slowing of conduction. The second-degree heart block, the PRI is lengthened, and then there is an absence of that next rhythm. So you're going to see the P waves and maybe not a QRS. And then the third-degree heart block is, I've got a pop-up down here that's not letting me see the bottom of my screen. There we go. The third-degree heart block is the atria and the ventricles are living a completely separate life. They're each doing their own thing because there's complete blockage in that heart. So the mouse has chewed the wire. All right. In terms of severity, our first degree, we could call that incomplete. There's just a delay. And then as severity increases, we're looking at a Mobitz type 1 or a Mobitz type 2 second degree block. So we're going to see some dropped beats. And then as we increase the severity, we're going to see a complete or third degree heart block. The key indicator for figuring these out is the PR interval. Okay, so rule out the second degree AV block Mobitz 1 and 2 by looking at the PRI. So the second degree AV block Mobitz type 1, the PRIs progressively lengthen. So gradually we're getting a longer PRI and then a missed QRS. The second degree Mobitz type 2, the PRIs are consistent, but we see intervals of a P wave and then no QRS. And then a complete or a third degree AV block, the PRIs are inconsistent lengths. So they're kind of all over the place because, like I said, the P wave and the QRS are just living completely separately or independently. So the first degree heart block, we are wondering, where did the P go and where is the QRS? So we are wondering why it's taking so long for that conduction to happen. The PRI interval is greater than 0.20 seconds. So as you can see here, we have a P wave that's long and a PRI that's too long and a PRI that's too long and a PRI. So there's just a delay in that conduction. The QRS is typically normal in these. And again, here is an example where the PRI is just too long. The rest of the rhythm, we almost could say that it's normal. It is regular. And there are some cardiac meds like beta blockers and calcium channel blockers that could cause this delay, as well as a heart attack. So that would be like some faulty coronary perfusion in the myocardium or heart muscle, or even an electrolyte imbalance. Our patients may be symptomatic, but as the delay or conduction problem continues, they're going to have more symptoms of fatigue, chest pain, sweaty, diaphoretic, lightheaded, dizziness. So usually the first degree and sometimes second degree blocks are asymptomatic, but the most common signs and symptoms, as I mentioned in the previous slide, there's a typo there that should say severe bradycardia, hypotension, fainting, chest pain, dyspnea. Right? Now moving into the second degree. And as I said before, there's a Mobitz type 1 and a Mobitz type 2 second degree. Many times you're going to hear the word Wenckebach in response to the Mobitz type 1. And what's happening is the delay is now going from a first degree to a second degree because it's gradually increasing. That PRI is gradually decreasing. And then all of a sudden, there's a drop or a lack of conduction to that ventricle or the QRS. So here's a second degree AV block Mobitz type 1. Again, it could be called a Wenckebach. The P waves look very similar, but the PRI continues to lengthen. So here we have a little bit of a first degree block because the PRI is too long, and then it gets longer, and then it gets longer, and then it gets even longer, and there's a dropped QRS, and then it starts again with just a little bit abnormal, even more, so on and so on. A second degree type 1 or Mobitz type 1 Wenckebach, this is another example. So the patient's going to feel some skipped heartbeats, maybe fainting and dizziness. So again, PRI is okay, but a little longer, even longer, and really long and a dropped beat. All right, the Mobitz type 2, we're wondering if the QRS is going to answer at all. So what's happening here is that there is a block between the AV node and the bundle of His. And what's happening is this PRI is here, and it's staying the same, and then just a random dropped beat. So the PRI is lengthened like a first degree, but it's so bad that we are actually having dropped beats. Okay, here again, we can see the PRI. That one looks okay. That one looks okay. Looks okay. Looks okay. And then there's a conduction delay there. That can be the result of heart attacks, heart surgery, heart disease, where something is just not right. So you can see here the P wave dropped the QRS. And the P wave dropped the QRS and then tried to go again. And then the P wave dropped the QRS. Management and treatment. If there's an electrolyte imbalance, you could fix that. Maybe a pacemaker at this point. Okay, and then third degree or complete heart block. Third degree heart block is seen most commonly due to degeneration. Okay, so that degeneration could be the result of disease or a previous heart attack or cardiac drugs like beta blockers and calcium channel blockers. Third degree heart block, we'll talk a little bit more about that. This slide isn't as important, but we're looking at a problem with cardiac output at this point, so lack of perfusion. Like I said, this is called complete heart block. It's the most common cause of abnormal bradycardia in PEDS patients, and there is complete disassociation between the P waves and the QRS complexes. So we can have P waves going and ventricular QRS complexes going, but they aren't talking to each other at all. They have a completely different lifestyle going on. So I like this animation here of, in pink back here, or red, are our P waves. And they're just going along, doing their own thing. It's a completely separate roller coaster. And then we have our QRS and our repolarization, and our QRS and our repolarization, and they're riding their own ride. So the P waves and the QRS complexes are completely independent. Okay, the disassociation between the atria and the ventricles results in two separate rhythms superimposed on the EKG. So there is a very high risk of sudden cardiac death with this because perfusion is minimal. So the brain's not getting good oxygenation because the heart is not effectively pumping. So there's no communication between the atria and the ventricles. And here on the cell phone, the right atrium is saying, is the track broken or something? And it says unable to deliver. So there's no communication. In AV block, common causes are myocardial necrosis. And what that means is death of the tissue of the heart muscle due to lack of oxygen or ischemia. Congenital anomalies, maybe a child was born with some defects of the heart, and it can cause that as well, or drugs, and like I said before, the degeneration due to disease. Here is an example, I know it's kind of blurry, of our third degree AV block. The atrial and ventricular rhythms are depolarizing independently. And this one's not such a great picture, but as you can see, there's P, 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 but the QRS complex isn't coordinating with the P. They aren't communicating. It's going completely separately. And there's a better picture in some of these other ones, but here's a ventricular rhythm, or a QRS, and then there's a P, and then there's a P, and then there's a QRS, and then there's a P here too, and a P here, and a P, and a QRS, QRS, QRS. So there's complete dissociation. It is the only heart block where P waves can be buried. So as you can see in this one, our P waves would be regular. They're evenly spaced. And the QRS complexes are just coming in, and they're regular too, but they aren't coordinated with the atria. So they're just coming in whenever they want. And it might just happen where the QRS complex comes around the same time as the atrial complex, and it gets put into the QRS complex. So you can see that little notch there. And the P wave here, that's not a T wave, and a P wave here. Complete AV block can be because of an inferior wall heart attack, or MI, and drug effects, vagal tone, electrolyte imbalances, or even illness or infection of the myocardium. They are going to need a pacemaker at that point if it can't be corrected. Third degree AV block, again, here's another example of our P wave. Our P wave, there's a P wave, 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 P wave. They're completely regular. The QRS is regular as well, although look at the rate of that QRS. It's very, very low. They are not working together. They are completely separate. Okay, the heart block poem, this is going to be something that I want you to take note of, even maybe make a flashcard, because as you're answering test questions on your national exam, it's going to help you determine the differences between some of these blocks. So if the R is far from the P, as in a long PRI, then you have a first degree. So if the R is far from P, then you have a first degree. We're lengthened right there. Longer, longer, longer drop, then you have a Wenckebach. And that is our second degree type 1 Mobitz or Wenckebach. Our second degree type 2 Mobitz is if some P's don't get through, then you have a Mobitz 2. And then our third degree or complete heart block is if P's and Q's don't agree, then you have a third degree. So I'll read that one more time for you. If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a Wenckebach. If some P's don't get through, then you have a Mobitz 2. If P's and Q's don't agree, then you have a third degree. All right, so here's a comparison. This slide might be helpful for you to print off or even maybe draw on a flashcard or even create some digital flashcards, but it compares the first, second type 1 Wenckebach, second type 2, and then the third degree. Okay, and then arterial stenting, I just want to tell you a little bit about that. That helps you have an understanding. But when there's a plaque buildup, they actually can insert a catheter into that coronary artery and dilate that balloon at the end, like this, and it will squish away or push away some of that plaque the best that they can. And around that is a stent. And when that stent is in place, it can actually be left in place to inhibit further development of that plaque for the future. So that's what a cardiac stent is. And they can place those when they do a cardiac catheterization, when somebody might come in with chest pain or have a history of heart attack, and they go in and they find that there actually is a blockage in one of those coronary arteries. Then they'll place a stent to help open up that blood flow. All right, I mentioned before, I think, that sometimes children are born with congenital anomalies of the heart, and that can create a heart block as well. At that time, maybe they would have to do a surgical repair or even implant a pediatric pacemaker. All right, Holter monitors. I wanted to go over this with you guys because they call this an ambulatory type of EKG because this little monitor right here, they actually can take home. They don't have to stay in the hospital. It's typically done in a 5-lead fashion, and it is an ongoing recording of their rhythm. So after typically 24 hours, they bring it back to the office. There is a recording device in here, sometimes like a micro USB, but they can download that into the database and take a look at what the patient's heart was doing while they were living their normal lifestyle at home. So maybe they were mowing the lawn, taking a walk, taking a nap. They can look at how the heart tolerated that and help patients understand maybe why they were having chest pain or abnormal rhythms or fluttering of their heart. Cocaine is one thing that we should take into consideration when we're looking at younger people, typically with heart conditions. So many times heart conditions are the result of a prolonged disease process in older patients, but younger patients who may have been cocaine users in the past or currently, we should understand that there's some differences with those types of patients because it can catch you by surprise. So with cocaine use, we have increased amounts of these plaques developing in the coronary arteries and arteries throughout the body, which results in high blood pressure and decreased amounts of oxygenated blood going to the heart, as well as spasms of those vessels, which results in these abnormal rhythms. So while you might not be expecting that in a younger person, definitely pay attention to their medical history and history of drug abuse. And if they are going to be going under anesthesia, there's special considerations to think about because anesthesia can react very negatively with vasospasm and cocaine use. Some people have a belief that there's some natural remedies to keeping our heart healthy, and there's some truth to that. I went ahead and posted some of the most popular beliefs surrounding that there, because you will have patients that come in, and taking their history, you need to include these types of natural things because they actually can inhibit or alter the way that our traditional medications work for them. All right, and coming to the end here, I want you to take a look at this rhythm and see if you can tell me what it is. So if we take a look at the PRI, we see that there is a little bit of a delay, but the QRSs look normal for the most part. The PRIs aren't gradually lengthening, so we know it's not a type or a Wenckebach. And then we suddenly have a drop here in our QRS complex. So we don't have a complete block because they are working together. We have a P and a QRS. It's not a first degree because there is a drop to B. It's not just a conduction delay. And it's not a second degree type 1 because they aren't gradually going. So this would be a second degree Mobitz type 2. When they're working together, a little bit of a delay here, but then a dropped QRS. All right, and I would like you to see if you could find examples of all 4 of our heart block rhythms and post those in our assignment section of Google Classroom. If any of you have questions, you should contact me, and you can send those via text or even through Google Classroom or even Remind 101 or email. So you've got a handful of different avenues where you can get questions answered. And I think that this is going to greatly help you differentiate between other rhythms, especially junctional rhythms, as well as determine what type of a heart block it is. All right, guys, thank you for taking the time to listen, and I will post this in our YouTube channel as well as our Google Classroom stream.